All right, this is chapter 27, Trauma Overview. Talking about the trauma patient, the trauma system. Our overview is going to be the kinetics of trauma, mechanisms of trauma, the multisystem trauma patient, the golden period and platinum 10 minutes, the trauma system, golden principles, and pre-hospital trauma care. Again, we'll begin with a case study. EMTs respond to a report of a person shot in a hunting accident. After a 15-minute response to the remote area, they meet state police on the scene. Police confirmed that it was a hunting accident and all weapons have been secured. The patient, a 27-year-old man, was accidentally shot by another hunter with a high-velocity rifle. As the EMTs size up the scene, they see a police officer holding direct pressure on the patient's thigh. The patient is lying supine on the ground and seems combative and confused. He is pale and sweating despite the cool temperatures. What are the priorities in managing this patient? What information will help the EMTs determine the extent of the patient's injuries? So I'll go back, give you a few seconds to read over that again. All right, as before, in all of our other presentations, I'll ask you to go ahead and take some notes, write your answers down, and see if they get answered as we go along with our presentation. All right, trauma makes up a significant percentage of all of the calls to which pre-hospital personnel respond. Recognizing the extent of the injury is critical to making decisions to giving trauma patients the best chance of survival. The kinetics of trauma. The mechanism of injury, or MOI, is how a person is injured. The science of analyzing mechanisms of injury is the kinetics of trauma. Kinetics is the branch of mechanisms dealing with the movements of bodies. Understanding kinetics is helpful in understanding MOI and trauma. Mass and velocity. So kinetic energy equals mass times velocity squared divided by 2. The velocity is the more significant factor in determining the amount of kinetic energy. Estimate the speed of the objects involved, motor vehicle collisions, and penetrating trauma. There isn't any way to tell how fast those objects are going. We will have to estimate. Acceleration and deceleration, the law of inertia. A body at rest will remain at rest, and a body in motion will remain in motion unless acted upon by an outside force. A faster change of speed, acceleration or deceleration, results in more force exerted. Energy changes form and direction. Energy travels in a straight line unless it meets interference. Interference with the travel of kinetic energy can cause it to change direction and form. 3 types of impacts in a vehicle collision. Energy is absorbed in each impact, and there can be multiple impacts of each type: vehicle collision, a body collision, and organ collision. Here we see a vehicle that strikes a tree. The vehicle is moving forward, hits the tree. The occupant continues forward and strikes the inside of the automobile. So we see the body collision with the steering wheel could result in broken ribs. The organs continue to move forward and strike the inside of the skull, chest, or abdomen, causing damage possibly. All right, click on the factor that most significantly determines the amount of kinetic energy involved in a vehicle collision. I'll let you think about it for just a second. It is D. The velocity or speed involved in a collision of 2 objects is the greatest determinant of kinetic energy. All right, MOIs. MOIs provide a suspicion of injury, not an accurate indicator of injury. You must assess the patient for indicators of injury. In vehicle collisions, have a high suspicion of injury when there is death of another vehicle occupant, altered mental status, intrusion over 12 inches for the occupant's sight, ejection from the motor vehicle, vehicle telemetry data consistent with a high risk of injury. So if you look back up at the top where it says death of another vehicle occupant, this means you have a patient that is not dead, and if you have a patient that is dead, you're gonna have a high index of suspicion for traumatic injury for that patient that you are going to be ultimately working. Types of impacts in motor vehicle trauma and their incidence of frequency in urban areas by percentage. 38% of all crashes are rotational, where they roll over. Lateral impacts, 15%. You got your T-bones. Your front end collisions, 32%, and rear ends, 9%. A frontal impact. The occupant is traveling at the same speed as the vehicle. Pretty significant crash with a tree. In frontal collisions, the occupant continues to move forward at the same speed the vehicle was moving. So that vehicle has something has caused it to stop, but your body will continue to move forward. With an up and over pathway, look for injuries to the abdomen, chest, face, head, and neck. So that's up and over, and you can see the indicators here. Meaning up and over the steering wheel is what they're talking about. So we have the head, face, neck, chest, and abdomen. A deformed steering wheel indicates possible chest or abdominal injury. You can see the steering wheel here is bent really, really significant. So you might not be able to see, well, you may be able to see contusions on the outside, maybe some flail chest, but abdominal injuries, you may not be able to see internal bleeding. So you would have to assess for that. The paper bag syndrome results from compression of the chest against the steering column. So on the left we have lungs. The epiglottis is closed. The lungs are expanded, and then the lungs rupture from compression from hitting that steering wheel. With a down and under pathway, look for injuries to the knees, femurs, hips, acetabulum, and spine. So here we go. Knees, femur, hips, the spine. That's an down and under pathway. Examples of MOI associated with frontal impact. Up here on the left, top left, you see a fracture of the hip or pelvis. Dislocated hip or knee. Lap belt is installed. Facial injuries from hitting the dash. No seat belt, neck injuries, amongst other things. All right, rear end impact. Initially, the head and neck are whipped back, which is where we get our whiplash injury. A properly adjusted headrest and seat belt reduce injury. Subsequent injury can follow up and over or down and under pathway. That's a very, very significant rear end impact. Alright, so effects of driver not wearing a seatbelt. Figure A, in a rear impact with an unrestrained occupant, initial movement is backward, causing potential neck injury, as we can see here. B, the occupant then moves forward, causing impact to the head and chest. So two things are happening, A and B. A goes back, B he goes forward. Lateral impacts. There may be injuries of the head, neck, chest, abdomen, pelvis, and extremities. Assess whether the patient bore the brunt of the impact. So if he was sitting in the front driver's seat and that's where the impact happened, then he bore the brunt of the impact. There we go. Lateral impact. See those airbags are deployed. Lateral impact causes impact to the head, shoulders, lateral chest, lateral abdomen, lateral pelvis, and femur. Here we go. Rotational or rollover crash. Injury patterns are less predictable. In rollovers, there are multiple impacts and changes in direction. Multisystem trauma is common. Ejection is common with rollover. Crushing injuries to ejected occupants are common. There we go, rotational impact. A lot of things came off that car during the rollover. Hopefully the patient did not. Again, a rollover impact. Alright, in a rollover of an unrestrained occupant, impact to the body is difficult to predict and commonly results in multiple system trauma. So you can see this unrestrained occupant here. I mean, and it all depends on actually how fast the car is rolling over. But I wouldn't want to be unrestrained rolling over at any speed. Okay, vehicle and pedestrian collision. The extent of injury depends on the vehicle speed, what part of the body is hit, how far the pedestrian was thrown, the surface the pedestrian landed on, the body part that first struck the ground. Injury patterns are different in children and adults. So let's review this really quick. What part of the body is hit first? Okay, so that's whatever part of the body was hit by the car. So there's two different things we got to look at here. What part of the body was hit by the car? And you look down a couple bullets. It says the body part that first struck the ground. So there's going to be two types of impacts: impacts with the car or the vehicle, and then an impact with the ground. And we need to be concerned about the surface that they landed on. Was it grass, mud, dirt, concrete, asphalt, construction equipment, a fence, sharp objects, jaded objects, that sort of thing. And the injury patterns that are different in children and adults, because adults are taller mostly and children are not. So where an adult might get hit in the femoral region, a child might get hit in the thoracic region. Restraints, a cause of hidden injuries. So seatbelts are good, but they can cause hidden injuries. The benefits of restraints outweigh the risk, but they are associated with certain injuries that must be suspected. Injury is more likely if lap belts and shoulder straps are not positioned properly. Airbags are not designed for multiple collisions. So what that means is airbags are deployed. They're deployed once, not designed for multiple collisions. And we see seatbelt injury to the upper chest, a lap belt injury to the abdomen. Considerations for infants and children: the head and neck are not secured. The head snaps forward, straining the neck. Spinal cord injury can occur even without injury to the vertebrae. Car seats should be placed in the back seat of the vehicle only. And the reason for that is because of the airbag deployment in the front. Motorcycle collisions. Helmet use is a significant factor in reducing morbidity and mortality. Impacts may be head-on or angular and may involve ejection. Laying the bike down can result in severe abrasions and burns. Some of you may know someone who's been in a motorcycle crash before. Here we go. Motorcycle collisions can result in multi-system trauma from multiple impacts to the rider. Key word is there, multiple impacts. Soft tissue injury to the face. All-terrain vehicles. A lot of crashes occur for people being irresponsible. They are unstable and easily tipped over. And collisions are similar to motorcycle collisions. So there you go. Someone being irresponsible on a four-wheeler. Some of you probably know someone like this or have been this person. No judgment here. Be safe. Alright, falls. Severity of trauma depends on the distance of the fall, the surface of the fall, and body part that impacted first. A severe fall is greater than 20 feet in an adult and greater than 10 feet or 2 to 3 times the height of a child. And these will be your protocols if you go to work with your local ambulance companies. They use these protocols for falls. Feet first falls, injuries to lower extremities, injuries to spine, injury to internal organs, wrist and elbow injuries may occur. I worked a call one time where some kind of it was a break-in home invasion, and one girl went up and hid in the bedroom on the second floor. And I was a police officer. When we got there, we looked up, and she was coming out of the second floor window into this little shingled roof area. And we were like, don't jump, don't jump. But she jumped anyway, feet first. Compound or open fracture to her ankle occurred, and it was pretty gruesome. All right, in falls, the energy of the impact transmitted upon the skeletal system. So, force transmitted to vertebrae causing compression fractures, we see right here. And then falls where the victim lands on his feet often fractures the lumbar spine. All right, head first falls, upper extremity injuries, head and neck injuries, chest, spine, and pelvis injuries may occur. Penetrating injuries. Kinetic energy predicts the amount of damage, low, medium, or high velocity. All right, it's penetrating. The severity of injury caused by penetrating trauma is related to the velocity of the penetrating object. So here we hear this bullet points to small area of tissue destruction. This is obviously a gunshot that's happening. High velocity, medium energy. Okay. High velocity, medium energy gunshot, fracturing the femur, shattering. Looks like you'll have. This is without the a straight through, no shatter of the femur. This is just a break. Shatter of the femur. You're going to have a larger tissue destruction here because of the shattered bone, or what they call an exploded limb. Low velocity, a knife or similar object can include defensive slash wounds, and the length of the object provides clues to the injury. So if you have the object, if you have the knife or whatever penetrated, and you know the length of it. Medium and high velocity injuries include pellets and bullets. Shotguns and handguns are generally medium velocity. High velocity weapons include rifles. Damage is determined by the trajectory and dissipation of energy. Dissipation of energy is affected by the drag, profile, cavitation, and fragmentation. And let's see, we're going to hopefully get to these 4 bullets right here. If not, I'll cover it for you. Gunshot wounds. 90% of fatal wounds involve the head, thorax, and abdomen. Wounds also occur in the neck and extremities. So, all right, let's go back here. All right, so dissipation of energy affected by drag. When a bullet enters the body, and when you think about drag, how is it pulling through, and is it just clean? Is it going through clean, or is it rolling and spinning? It all depends on the trajectory, but the drag could create a lot of internal injury, a lot of tissue damage, a lot of bone damage. Your 22 long rifle or 22 shorts, they call them the bouncing betties because they'll enter the body, and then they're not high velocity enough to go through and through. So what they do is they bounce off of a bunch of things, creating a lot of drag, creating a lot of tissue and organ damage. You can actually look up a video. It's Trooper Mark Coates, and he was shot with a 22 Derringer in the lateral thorax, and he was literally dead before he hit the ground. And it was very sad, but it's just an example of the difference in velocities and how it works and things like that. Profile, the shape of the bullet. Cavitation, whenever it enters the body, how big of a cavity does it make? So there's hollow points, there's your ball ammunition. So hollow points are going to obviously create more of a bigger cavity. And then fragmentation, does the bullet break up when it hits and enters the body? Some bullets are designed to do that. So that's some of the things you need to think about when you get on scene. Okay, so if you've experienced some severe trauma, severe bleeding, you might be inclined to believe that it was some sort of bullet that caused a lot of drag, fragmentation, big cavitation, such. All right. Blast injuries occur from explosions. Each of the phases of an explosion causes specific types of injury, and we'll talk about the phases of explosions. An explosion releases tremendous amounts of heat energy, generating a pressure wave, blast wind, and projection of debris. There's a big explosion right there, big picture of it. All right, so figure A, pressure wave is your primary injury. Air molecules slam into one another, creating a pressure wave moving outward from the blast center, causing pressure injuries. So simply the pressure from the blast. Blast wave, secondary injury. Instantaneous combustion of the explosive agent creates superheated gases. The resulting pressure blows the bomb casing apart. Pieces of the bomb projectiles can cause secondary injuries by striking the patient. This is what we call shrapnel. The military calls shrapnel. In figure C, patient displacement or tertiary injury. And I'm going to tell you really quick that you're going to see this on the test and on the written at the end of the class. So you need to know the different phases of blast injuries. C, patient displacement, tertiary injury. The blast wind may propel the patient to the ground or against objects, causing further injuries. And then D, patient exposed to hazardous material or structural collapse, quaternary or quinary injury. This is the patient may also be exposed to harmful chemicals or toxins, or may be injured by structural collapse. So a lot of things can be going on in explosions. So you need to look at that slide. You need to look in your textbook and understand blast injuries. All right, Nina and Scotty ensure the patient has an open airway and is breathing adequately, and apply oxygen by a non-rebreather mask as the police officer continues to apply direct pressure. Nina detects a weak, thready radial pulse that she estimates to be greater than 100 per minute. She performs a rapid secondary assessment, during which she finds an entry wound to the front of the thigh and exit wound posteriorly. Meanwhile, Scotty is preparing a long backboard so they can prepare the patient for transport. What factors should EMTs consider in determining where the patient should be transported? I'll give you a few seconds to write down your thoughts. All right. Multisystem trauma patient. Most trauma patients have a simple or single injury. Most trauma patients have a simple or single injury. Multisystem trauma has a high incidence of morbidity and mortality. Managing immediate life threats and expeditious transport are the appropriate care. Loading a multisystem trauma patient at the rear of the helicopter for rapid transport to an appropriate facility. The golden period and platinum 10 minutes. The best chances of survival for trauma occurs when intervention takes place as quickly as possible. The goal is for EMS providers to limit scene time to 10 minutes with severely injured patients. So you will see this again. Hint, hint. Within a 10-minute scene time, you must assess the patient, manage immediate life threats, and prepare the patient for transport. All right. Indications for on-scene time of 10 minutes or less in rapid transport. Airway occlusion or difficulty in maintaining a patent airway. Respiratory rate less than 10 or greater than 29. Inadequate tidal volume. Hypoxia. Respiratory distress, failure, or arrest. Suspected skull fracture. Flail chest. Suspected pneumothorax, hemothorax, or tension pneumothorax. Pelvic fracture. 2 or more proximal long bone fractures. crushed or mangled extremity, uncontrolled external hemorrhage, suspected internal hemorrhage, signs and symptoms of shock, significant external blood loss with controlled hemorrhage, Glasgow Coma Scale 13 or less, altered mental status, seizure activity, sensory or motor deficit, any penetrating trauma to the head, neck, anterior or posterior chest, abdomen, and above the elbow or knee, amputation of an extremity proximal to the finger, trauma in a patient with significant medical history, for example, myocardial infarction, chronic obstructive pulmonary disease, and congestive heart failure, greater than 55 years of age, hypothermia, burns, or pregnancy. Multisystem trauma, open or depressed skull fracture, suspected brain injury, and paralysis. All right, the trauma system. The trauma system exists to provide immediate surgical intervention for critically injured trauma patients. Different levels of trauma centers have different levels of capability. This care dramatically reduces the morbidity and mortality of patients requiring immediate surgical intervention. Here we go. The St. Louis Fire Department ambulance pulls up at the Charles F. Knight Emergency and Trauma Center. Basically what they're trying to tell you here is that you need to get to know your hospitals and where your different centers are. You don't want to just bring them to a basic ER if they can't handle major trauma. There are different levels. Level 1, which is a regional trauma center. Level 2 is an area trauma center. Level 3 is a community trauma center. And level 4 is a trauma facility. So level 1 being your greatest. All right. So here we go. Field triage, injured patients. And let's see if I can zoom in here. And I cannot. Hold on. Okay. Well, we're just going to try to read this here. So we see number 1, measure vital signs and level of consciousness. Looking at the Glasgow Coma scale of less than 13, systolic blood pressure at less than 90, and respiratory rate less than 10 or greater than 29. If those answers are yes, you need to transport to a trauma center. Steps 1 and 2 attempt to identify the most seriously injured patients. If it's no, then we assess the anatomy of the injury and so forth. So you can read this on your own and follow it down. And kind of, it would be something you have to memorize, but also your local protocols may be different, but hopefully they all are trying to follow the CDC guidelines. So if you look down at the bottom of this little placard, it says, when in doubt, transport to a trauma center. And there you go. And you can look it up at cdc.gov/field triage as well. All right, golden principle for pre-hospital trauma care. The golden principles of pre-hospital trauma care apply to all patients who have experienced some type of injury, but especially those with multisystem trauma or critical injuries. Special consideration in trauma care: your personal safety is the highest priority. Airway management and adequate ventilation and oxygenation are key elements of trauma management. Stop significant bleeding. Assessment of the trauma patient is conducted in a systematic sequence. This is why we teach this in our skills and scenarios, so that you have to get this process down. Okay, and always remember that we're treating life-threatening emergencies in the primary assessment. Special considerations: rapid transport is essential to survival of severely injured patients. A backboard serves to splint fractures in unstable trauma patients. Also a stretcher. Do not develop tunnel vision and become focused on dramatic injuries or patients. So if there's a serious arterial bleed, don't get, you're going to treat it, but don't get sidetracked by it. You still need to do your patient assessment. And don't think that's the only thing that's going on, because that might be the less severe of the things that are really happening. So still need to treat it, but you still need to pay attention to other things. Okay, case study conclusion. Nina consults with medical direction concerning their destination for the patient. There is a community trauma center for 20 minutes away and a regional trauma center 70 minutes away. Medical direction advises transport to the community trauma center, where the patient will receive initial stabilization. It is likely that the patient will be transferred to the regional trauma center for definitive treatment. All right, our summary: assessing the MOI helps to predict potential injuries. Mass and velocity are the determinants of kinetic energy. Trauma may be blunt or penetrating. High velocity weapons are particularly prone to producing massive bodily injury. Trauma systems exist to allow rapid surgical intervention for severely injured patients. Trauma triage criteria help determine which patients should be transported to a trauma center. All right, I appreciate you sticking around.